Care for a patient with kidney stones or renal calculi. So as always, it is very important to obtain the history and physical of the patient. So if they're experiencing pain, we need to know where and when is it happening, any trend, any particular pattern of pain, what makes it worse, what makes it better. Also, it is very important to obtain history of kidney stones, medications that they're taking, any diet, any family history, and their fluid intake. In addition, physical assessment is essential. So we need to know where's the pain, right? Is there any tenderness when they're passing urine? How's the urine? Is there any blood in the urine? What's the color? And also vital signs, temperature, heart rate, blood pressure, and so on. Also pain level, describe the pain. And then pain control is important. We have discussed that renal calculi or kidney stones can be quite painful. Like I said in class, it can be worse than giving birth. So that's actually very painful. So anyhow, pain management is important. We can manage the pain usually with some NSAIDs. Sometimes some patients, depending on their pain tolerance, they may need stronger pain medications. But typically, especially in the outpatient settings, they can get by with some NSAIDs just to kind of help manage the pain a little bit. It may not take it completely away, but at least something to make it a little bit more manageable. And like I said in class, we also administer alpha blockers such as tamsulosin, which helps relax the smooth muscle. So we have to think about where are the alpha 1 receptors, right? So typically it's located in many different sites, like vessels, but they can also be found in the ureters, in the bladder, the prostate area. So those are smooth muscles. So alpha 1 blocker actually helps relax those. So it facilitates the passing of the kidney stones or renal calculi. In addition to that, especially with lithotripsy, right? With lithotripsy or with or without, we want to make sure that we educate the patient and let them know that they have to strain their urine because you want to determine if they actually pass the kidney stones. In addition, definitely pre-op and post-op care of patients undergoing lithotripsy and patient education is essential. So we have to talk to them about their dietary changes, making sure that they're having adequate intake, and definitely they need to be active, not sedentary. So dietary changes definitely reduce food that can put them at risk for developing kidney stones. And then, like I said earlier, fluid intake is very important. They need to make sure they're properly hydrated to help dilute and prevent stone formation. And then physical activity prevents bone resorption, therefore helping decrease the calcium levels in the blood and then reducing the risk for developing kidney stones. So what do we do if a patient is undergoing a lithotripsy? So pre-op, like always, we need to assess the patient's knowledge regarding the procedure, make sure that they actually get informed consent. So meaning the provider should have discussed the risks, benefits, and options pertaining the procedure and the patient should have an opportunity to ask questions regarding the procedure. If it's non-emergent, which is typically a lithotripsy is not emergent, we need to make sure that we have some bowel prep done, right? Their GI tract is empty, and then they should have been NPO. Now, post-op, after the procedure, definitely it is very important to monitor the vital signs, any signs and symptoms of infection, any potential signs and symptoms of complication, their pain levels. Definitely we need to monitor their intake and output, making sure that they're urinating, right? We're not causing more obstruction by breaking down the kidney stones and then letting it basically get stuck in the ureters, right? So we need to make sure that they're having adequate output and monitoring the color, also making sure that their urine is being strained. So if they're going home after the procedure, then they need to be straining it. If they're staying inpatient, we need to make sure that that's happening too at the bedside to make sure that we can monitor if they're passing the kidney stones. And definitely discharge teaching. make sure that we're providing education not only to the patient, but especially if they're going home and a family member is helping care for that patient, or maybe a caregiver is taking care of that patient after discharge. They need to know how to care, when to report, when to call the doctor, what are the things that they need to expect, and then answer any questions that they may have. Some of these patients may be going home with a Foley catheter, so if that's the case, definitely we need to make sure that they're doing proper Foley catheter care, right? Making sure that the bag is below the bladder, make sure that it's flowing, making sure that there's no obstruction, making sure it's not getting pulled, getting any infection. Hygiene is very important, so just educating them to keep it clean. If it's a more invasive lithotripsy, right? So if it's percutaneous, then definitely if there's any dressing change, we need to educate them or arrange for that to happen. And then making sure that they may need to change their lifestyle to prevent any more kidney stone development, making sure that they're well hydrated. So again, dietary changes and ensuring appropriate or even more fluid intake to prevent recurrence of kidney stones. So priority problems for patients with kidney stones or renal calculi can include impaired urinary elimination, acute pain, fluid volume deficit, activity intolerance, risk for infection, and knowledge deficit. Benign prostate hyperplasia, or BPH. BPH, or benign prostate hyperplasia, is basically the enlargement of the prostate, and it's not necessarily cancerous. So depending on who you're talking to, they may call it benign prostate hyperplasia or benign prostate hypertrophy. Academically or clinically, hyperplasia and hypertrophy means different things, but in this specific condition, they are being used interchangeably. So hyperplasia, technically, it refers to an increase in the number of prostate cells, while hypertrophy means the increase in the size of the prostate cells. Anyhow, know that there's a difference between those terms, but specifically for BPH, they're actually being used interchangeably. Anyway, so BPH, typically it happens starting at the age of 40 to 45, and it is quite common. So it affects about 50% of men greater than 60 years old. So there are risk factors. Age is definitely a risk factor. The older men get, the higher the likelihood of developing BPH. Now, family history, so if it can run in the family, so if family members have the same history, they are likely going to develop it. So race-wise, it is more common among African Americans and not as likely in Japanese men. Now, dietary-wise, so it's more common in patients who have a high intake of meats and fat. So BPH manifestations, so think about it, the manifestations or signs and symptoms are really secondary to the obstruction because of the enlargement of the prostate gland, right? It can cause it to obstruct the urine from coming out. So anyhow, so what are the manifestations? So some patients may complain a diminished force of urinary stream. So when they're urinating, right, it's not flowing as forcefully as usual. There may be some hesitancy in initiating the urinary stream. So basically it takes them a little longer to get started. And there could be post-void dribble. Post-void dribble is basically when they're done urinating, they think they're done, and then next thing you know, it's still going or dribbling, dropping a little bit more even after they think they're done. In addition, some patients, even after completely eliminating or emptying their bladder, they can still feel like there's some more urine there, but it's actually the prostate putting pressure on the bladder. They can have urinary retention, or basically not passing urine, so staying there, nocturia, or urinating while asleep, and then frequent urination. And they may have a sense of urgency or urge incontinence, and for some patients, they may complain of dysuria or discomfort when urinating. Complications from BPH. So complications from BPH include bladder distension, infection, hydronephrosis, renal insufficiency. There is a misconception. Some people think that BPH can lead to prostate cancer. That's actually not true. BPH does not increase the risk of prostate cancer. So definitely please remember that. Anyhow, so bladder distension. So bladder distension typically is secondary to a couple of things. One, the enlarged prostate putting pressure to the bladder, and then two, the retained urine, which then the more urine you're going to retain, then the more the bladder is going to be distended. And so the problem with that, especially when it happens for a prolonged period of time or repetitively, it can lead to bladder damage. Now, infection happens due to urinary stasis. So again, this is from the obstruction leading to urinary retention. And we know if something is not flowing, if it's stagnant, then definitely it can cause bacteria to collect and grow, leading to a UTI, and at worst, the infection can actually climb up all the way to the kidneys, leading to pyelonephritis. So that can be quite dangerous for the patient. Another complication due to the obstruction is hydronephrosis. So hydronephrosis really means water in the kidneys. So it is typically due to the urinary retention. And if it's happening for a long time, this can lead to kidney damage. Now, again, talking about kidney damage, renal insufficiency is basically when the kidney function goes down. And again, this is typically secondary to the kidney damage from all the urinary retention, causing fluid to build up and damage the renal tissue. BPH diagnosis. So how do patients get diagnosed with BPH? So there are many ways, but it usually starts with patients' manifestations. So patients typically complain of urinary problems such as difficulty urinating, frequency, and so on. So when they do that, whenever they go to their provider, the provider will then try to figure out what's causing it, and depending on their age or risk factors, they may suspect BPH. So DRE, or digital rectal examination, some textbooks actually mention it, but basically this is the examination of the prostate through the rectum. So this is when they insert a finger through the rectum and kind of try to put pressure or palpate the prostate gland through there. Now, this is an old practice. Some physicians still do that, but it is actually not recommended. Studies show that there could be a lot of false positive results with the DRE, or digital rectal examination of the prostate. And in addition to that, if they actually have some sort of prostate problems, let's say they have prostatitis, which is the inflammation of the prostate, when a provider puts pressure on the prostate, it can actually make it worse. Or if there's any infection going on, right, that can actually cause more complications. So risk versus benefits, there is actually more risk for doing DRE than benefits. So it is actually not recommended to do a DRE. Anyhow, other ways to diagnose BPH would be through a post-void bladder scan. Basically, after urinating, the patient's bladder will be scanned to see if there's more urine in the bladder. So typically, right, the expectation is once you empty your bladder, there shouldn't be any urine. And if there is, there should be very little amount. Now, if there's a lot of urine after voiding, then that can raise concerns with potential obstruction. And again, for males, depending on their risk factors, most likely secondary to BPH. Now, post-void catheterization. So similarly, right, we ask the patient to void, and after voiding, we insert a catheter and measure the amount of urine that comes out from the catheter. Now, other tests that can be ordered when a patient has a potential, or I guess when a patient is being diagnosed with BPH, they may look at the BMP, or basic metabolic panel, typically BUN, creatinine, GFR, just to see the kidney functions, right? So maybe the urinary symptoms is actually kidney related, not prostate related. A UA can be done, again, because of the manifestations of BPH. It can be very similar to a UTI. Now, PSA, or prostate-specific antigen, is a blood work that is measured, and it kind of gives you an idea of how the prostate is doing. Now, it doesn't mean that the PSA is elevated, that it is automatically cancer. So what happens is PSA is measured and it's trended, and depending on how fast it goes up, if it goes up really quickly, then there may be some suspicion for prostate cancer. Now, that said, PSA typically goes up as men age. So again, not because their PSA is high that they automatically have prostate cancer. But definitely if there's any concern, right, because prostate cancer and BPH can have overlapping symptoms, right, you want to make sure that you're measuring that, and hopefully we can rule out prostate cancer. Also, in addition to that, some providers may order some serum acid phosphatase, which can kind of help detect for any cancer or metastasis. In addition, KUB or IVP. So KUB is basically an x-ray of the kidneys, ureter, and bladder, or it's also known as an abdominal x-ray. But it's also named KUB because of how the frame is, right? It includes the kidney, ureter, and bladder. Now, IVP is intravenous pyelogram, basically is a KUB, and they administer a contrast dye to visualize the kidneys and the ureters and bladder a little bit better. So this is the use of contrast to visualize the urinary tract. All right, BPH management. So typically they can be managed conservatively through medication, lifestyle changes, but at times some patients may need surgery. Anyhow, some medications that we give for BPH. So we can administer anti-androgen or a 5-alpha reductase inhibitor such as finasteride for this patient. So basically it works by blocking testosterone to convert into DHT. So that will allow the prostate to shrink or not increase in size. Now, the problem with that is it can lead to, so side effects can include impotence or problems with erections and also decreased libido. Now, in addition to that, we can also administer alpha adrenergic antagonist or alpha 1 blocker. So example of that, I mentioned it in the previous topic. Example of that would be tamsulosin and doxazosin. Again, remember that we also give this medication as antihypertensive. So let's say you have a patient who has both problems. So a male patient, maybe in their 70s, having BPH, and they also have hypertension. Well, to avoid prescribing so many drugs, right? Typically, the most ideal thing is give them one drug that addresses two problems. So in this case, right, if we give tamsulosin, it can help control their blood pressure, but also it can help with their BPH symptoms. So again, this works similarly to how it works with kidney stones. So because alpha blockers actually help relax the smooth muscle. So smooth muscle is also found in the prostate and in the bladder area. So that kind of helps to relax that area and allows urination to go smoothly without spasming. So that helps with the symptoms of BPH. Sometimes some providers may actually recommend some herbal supplements to help with this. So example of that would be saw palmetto and African plum. So these are over-the-counter supplements that are known to help with BPH symptoms. That said, we have to be very careful. So we have to educate our patient to be very careful when choosing to go with supplements, because we know that supplements are not as regulated as prescribed medications. So we don't know how pure they are, if they actually have any active ingredients. So some of the supplement companies are better than the others. So they just have to be very selective and making sure that they are getting what they think they're getting. Now, medications to avoid. So we need to make sure that we let our patients know, especially if they're very symptomatic, to avoid taking antihistamines and anticholinergic as much as possible, because this medication side effect include urinary retention. And we already know that BPH can lead to urinary retention. So we don't want to make the symptoms worse or actually cause complications because of the combination of the BPH manifestations and the medications that the patients are taking. So anyhow, so surgery. So surgery is not common, but it can be done when their symptoms are unresponsive to conservative treatment. So conservative treatment, so remember, conservative means that we're not doing anything invasive. So it's typically lifestyle changes, medication without surgery. now invasive, right, non-conservative way of treatment would be through surgery. Criteria for patients who are gonna likely qualify to get surgery due to a BPH include if they have chronic bladder infection, acute urinary retention, hematuria, hydronephrosis, and bladder neck obstruction syndrome, which can include manifestation of frequency and urgency. And again, surgery is usually the last resort, but patients can qualify for surgery, especially if they're having the symptoms or it's quite recurrent and it's affecting their quality of life. So BPH surgery. So the main goal of BPH surgery is to relieve the patient's symptoms. And so the main goal is to decrease the size of the prostate, right, to allow for urine to flow better. Now, there are different methods and approaches. One of the most common one that I've seen is TURP, or transurethral resection of the prostate. Now, there are different kinds. Like I said, there can be transurethral microwave thermotherapy. There's also TUNA, or transurethral needle ablation. There's also TUIP or TIP, which is transurethral incision of the prostate. So the resection, right? So whenever we say resection, is really removing part of that organ. So resection, transurethral resection of the prostate, this is the removal of the obstructing tissue. Usually it's using some electrocautery devices that scrapes off that excess tissue, and this is typically safer because it's not as invasive as the open surgery. There's less risk for hemorrhage, but you will still see blood in their catheter just because of it's a vascular area and it can still bleed, but definitely it has less risk for clotting, UTI, and less likely to have more complications. Typically, after this procedure, patients will end up with a 3-way catheter that will allow us to irrigate, right, to make sure that it's not clotting, and also it also allows us to basically keep the area open. Potential complications from this can include impotence, which is a big deal, especially for men, right? And other ways to resect the prostate include transurethral microwave therapy. So again, this uses basically the same goal, but different methodology. So in here, they use a microwave device. So it burns off the prostate gland and it reduces the size. So this is typically an outpatient procedure that lasts about an hour. Transurethral needle ablation. So this is another way of reducing the size of the prostate by using some needles to burn the enlarged prostate. The urethra is actually protected, and this doesn't usually lead to impotence or incontinence. Now, the transurethral incision of the prostate, this actually requires a small incision which splits the gland, and it will just relieve the pressure from the urethra. So this is only typically used if the prostate is not that large. There are other more invasive ways to resect the prostate. So these more invasive prostate resection surgeries are not commonly done, but if for one reason or another they're unable to do the less invasive ones, then these are the other ways that they can resect the prostate. So anyway, so let's this is another illustration that shows how TURP is done, right? So this is resection of the prostate, so that's TURP. And then here, this is another approach, which is the suprapubic or transvesical prostatectomy. This is really where the surgeon makes an incision on the suprapubic area, and that's how they access the prostate. It is actually more invasive, as you can see. And then another way is the retropubic or retrovesical prostatectomy. So as you can see here, they go directly through an abdominal incision, and again, this is gonna be more invasive. And another one is through a perineal prostatectomy. So as you can see here, this is the rectal area, this is the prostate, and this is, so it's kind of like in between. So sometimes they may need to access it that way. And again, the concern here, especially this approach, is a risk for infection, right? Because you see here the rectum is over here. So if a patient's having a lot of bowel movements, right, it is a risk for infection. But anyhow, these are the different approaches for prostatectomy. And like I said, these are not common, but these are different approaches depending on what's going on with the patient and also depending on the provider. Surgical care after a prostatectomy, pre-op and post-op. So pre-op, very similar thing that we've learned in the past, assessing for knowledge, making sure that they have an informed consent, that they had the ability to talk to the provider, and that the provider gave them all the information that they needed. So again, they have to, the provider should have explained the procedure, what to expect, such as having a catheter afterwards, potentially having a CBI or continuous bladder irrigation and other drains. Typically, that should be provided by the provider performing the surgery. And then as nurses, we just have to kind of reinforce that education done. Now, post-operatively, our role is to making sure that there's no complications, right? That they're recovering well. So vital signs, we need to take our vital signs, making sure that we are measuring accurate intake and output, checking for catheter patency, making sure it's flowing, there's no obstruction. Pain management is important, making sure that we're providing the necessary medications. And then labs, looking at the CBC specifically, right? We want to make sure that the patient is not bleeding, they're not developing any infection. SCDs to prevent clots from forming in their lower extremities, and definitely encouraging fluid intake, right? They need to be hydrated to kind of help flush all that clots that may be coming out through the urinary catheter. And definitely we need to assess for bleeding, infection, and obstruction. So we need to monitor the amount of clots. Ideally, over time, right, we need to start seeing lighter pink color, especially if, let's say, your patient has been there and it's already cleared, right? The urine is not as bloody. So it's more of serosanguinous, or even more, actually it's more clear or pinkish in color. And next thing you know, a few hours later, you see bright red and clots are coming out. Then you have to be concerned, right? We have to ask ourselves, is there bleeding happening? And also, if you're seeing a lot of clots and next thing you know, the catheter stops flowing, right? There's no more urine coming out. Then we have to be concerned of potential obstruction. And of course, infection, we need to kind of keep an eye on signs and symptoms of infection. So those are the main responsibilities of the nurse caring after a patient undergoes a prostate resection. All right, I mentioned earlier that some patients may need to be on a CBI or continuous bladder irrigation. So these patients will end up with a three-way Foley. Basically, the catheter will go in the bladder, right, to drain the urine, and then one tube goes to a fluid, right, an irrigation, so it's typically normal saline, and then the other part, the other tubing will go down to the Foley catheter bag. And the main goal for this, it provides traction on the prostate, so it prevents it from closing, right? It keeps the area patent, it keeps it in place. And then in addition, it helps wash out the clots and it prevents clots from forming, which can lead to obstruction. Now, caring for the patient when they have a CBI, again, importance of intake and output, assessing the urine, vital signs, definitely explaining what is a CBI, how it works, what we're doing. So every time we're doing something, we need to make sure that we're telling our patients. And then we definitely have to assess the catheter every 1 to 2 hours, and then looking at our patients' H&H, sodium, right? Anything that can affect the elimination of the patient. So for traction on the prostate, so traction, again, traction is to keep it in place. So this will be basically initiated by the urologist. The doctor will actually tell you to keep it in place. So please, if somebody has a CBI, don't just discontinue it on your own without consulting the doctor. And like I said earlier, CBI helps wash out a clot. So it's normal that it's bloody for the first few hours post-op. And so the bloodier it is, we need to adjust the rate of the normal saline, the flow rate of the normal saline to kind of help flush it out. And so the more we're flushing it out, right, it helps kind of clear it. It prevents clots from forming. typically it should clear out. Now, if all of a sudden the blood turns bright red again when it's already been cleared, it's been, let's say, a couple of days, again, we have to be concerned of potential bleeding. But if it's fresh post-op, that's typically expected. BPH priority problems. So again, urinary retention. So definitely we need to educate the patient regarding manifestation, checking for urinary obstruction or bladder distension, risk for infection. So monitor, assess for signs and symptoms of infection, looking at the labs, the vital signs, and so on, making sure that we're maintaining and cleaning the catheter. Also, risk for imbalanced fluid, so monitoring the vital signs, the color of the urine, the drainage, knowledge deficit. Again, it is important to educate the patient. And then pain. Definitely we need to educate the patient regarding the expectations when it comes to pain, but also we need to help manage the pain. All right, NCLEX questions. A client's plasma ACTH is decreased and plasma cortisol is increased. Which is the likely diagnosis? A. Addison's disease. B. Renal calculi. C. Myxedema coma. D. Cushing's syndrome. The answer is D. Next question. A client comes into the emergency department with Addisonian crisis. Which of the following should the nurse be prepared to administer to assist this client? A. Warm blankets. B. IV fluid. C. Thyroid replacement hormones. D. Blood transfusion. The answer is B. IV fluids. Next, a client with intractable asthma develops Cushing's syndrome. This complication can most likely be attributed to chronic use of A. Prednisone, B. Theophylline, C. Metaproterenol, D. Cromolyn or Intal. The answer is A. Prednisone, which is a glucocorticosteroid. Next, the nurse is instructing a client with oxalate renal calculi. Which food should the nurse urge the client to avoid? A. Citrus fruits, molasses, and dried apricots. B. Milk, cheese, and ice cream. C. Sardines, liver, and kidney. D. Spinach, nuts, chocolate, black tea, and asparagus. The answer is D. Spinach, nuts, chocolate, black tea, and asparagus are high in oxalate. Last question. The nurse is caring for a client with renal calculi. Which is the most important nursing action? A. Limit fluid intake at night. B. Strain the urine at each voiding. C. Record the client's blood pressure. D. Administer analgesic every 3 hours. The answer is B. Strain the urine at each voiding.